let's jump right into this explainer. Every single day, intensive care units are fighting a silent, completely invisible war. And we aren't talking about the initial traumas or the critical illnesses that brought the patients through the doors in the first place. We're talking about complications that develop right there in the ICU bed. Today, we're analyzing the latest CDC and WHO guidelines on a massive, deadly threat that can turn a life-saving ventilator into a huge liability. Let's break down exactly how medical professionals mount a tactical defense against this hidden enemy.
So, the very first thing we need to wrap our heads around is the sheer vulnerability of the patient. When someone needs mechanical ventilation, a tube is placed directly down their trachea. Now, obviously, this is a miraculous life-saving intervention, but it has a pretty massive physiological drawback. It completely bypasses the body's natural airway defenses. Your mouth, your vocal cords, your cough reflex, all those amazing things that normally stop bacteria from marching straight down into your lungs, they're just held wide open by a piece of plastic. It's essentially a direct express highway for pathogens, which makes ventilator-associated pneumonia, or VAP, an incredibly severe complication. But here is the crucial takeaway we'll see throughout this explainer. It's potentially preventable.
You know, for decades, getting pneumonia in the ICU was kind of just viewed as the inevitable cost of doing business. The thought process was, if you're on a ventilator long enough, you're probably going to get sick. But the modern medical mindset has completely radically shifted on this. We have to ask ourselves, how do we actually shield these highly vulnerable patients? How do we stop a preventable complication from taking root? Well, that question brings us to a highly structured, fiercely evidence-based tactical defense that literally rewrites the odds for patient survival.
Here is our roadmap for today. We'll cover 1. The invisible ICU threat. 2. The core VAP bundle. 3. Mastering tube hand hygiene. 4. Multimodal prevention strategies. And 5. Evidence, what actually works. Let's get to it.
Starting with Section 1, the invisible ICU threat. Let's take a look at what we're actually up against at the bedside.
Because this adversary is invisible, it requires a highly proactive defense. The guidelines are super clear here. VAP is a serious complication, but to fight it, you need to look at the broader picture. Enter VAE, or Ventilator-Associated Events. This is the CDC's objective surveillance definition, and it's used to track any deterioration in a patient's respiratory status. It catches VAP, sure, but it also catches things like fluid overload or acute respiratory distress. The core philosophy? You literally cannot manage what you don't meticulously measure. Strict surveillance of VAE is essentially the hospital's alarm system, and the VA Prevention Bundle is the tactical response to that alarm.
Moving on to Section 2, our primary tactical defense, the core VAP Bundle.
These 4 pillars are your cohesive shield. We've got strict hand hygiene, comprehensive oral care, elevating the head of the bed, and daily sedation vacations paired with breathing trials. But wait, it's absolutely critical to understand what a bundle actually means in modern medicine. A bundle is not an a la carte menu of good ideas that you just pick and choose from when you have time. No way. It is a locked-in set of evidence-based practices that, when you perform them collectively and reliably every single time, improve patient outcomes exponentially more than doing them solo. They are a powerhouse together, but they demand unyielding precision.
Let's actually zoom in on that last point, because the physiology is fascinating. Don't think of a sedation vacation as a relaxing break on a beach. Think of it as a suspenseful, high-stakes daily test. Sedatives pool in fat cells and heavily suppress the body's natural cough reflex. By pausing these meds, the team lets the patient wake up just enough to see, is their body ready to fight? Can they clear their own secretions? Pair that with a spontaneous breathing trial to see if they can support their own airway. Because the absolute best way to prevent a ventilator infection is to get that tube out as fast as safely possible. Now, obviously, clinical judgment is key here. You wouldn't do this for a paralyzed patient or someone with a severe traumatic brain injury who needs strict pressure control. We also use simple physics to build our defense. Gravity is basically a free intervention here. The rule is to keep the head of the bed elevated at 30 to 45 degrees. The stomach is basically a swimming pool of acid and bacteria. And if a patient is lying totally flat, all that gastric content can slowly creep right up the esophagus, sneak past the tube cuff, and pull straight into the lungs, causing massive aspiration pneumonia. Elevating the head stops that dead in its tracks. But, as always, there are crucial exceptions. You absolutely cannot elevate an unstable patient in profound shock who needs maximum blood flow to the brain, and you definitely don't move a patient with an unstable spinal or pelvic fracture where a shift could cause permanent paralysis.
And check this out, let's look at oral care. Did you know that within just 48 hours of being intubated, normal dental plaque transforms into this thick, nasty biofilm teeming with hospital-acquired gram-negative bacteria? It's wild.
So oral care is not just about having fresh breath. It is literally a tactical strike to wipe out a massive bacterial reservoir sitting mere inches from unprotected lungs. We aggressively go after those pathogens with regular brushing, mucosal cleaning, and antiseptic mouthwashes. But again, exceptions dictate the practice. You skip this aggressive protocol if the patient has profound facial trauma, recent reconstructive surgery, or a dangerous hypersensitivity to chlorhexidine.
Let's look at Section 3, Mastering Tube Hand Hygiene, the first and arguably most critical pillar.
This data from the World Health Organization shows the absolute, non-negotiable boundaries of hand hygiene around the airway. Think about a respiratory therapist or an ICU nurse. They might touch a ventilator circuit dozens of times in a single shift, and every single touch is a potential vector for a deadly infection. You have to perform hand hygiene immediately before any manipulation, adjusting the tape, doing oral care, or endotracheal aspiration. And then, boom, you wash immediately after any fluid exposure, like handling thick secretions or extubating. This isn't just a friendly suggestion. It is an absolute boundary required to protect the sterile zone.
Moving to Section 4, Multimodal Prevention Strategies. Now that the bedside is secure, let's zoom out to the whole hospital.
Because here's the reality. An isolated checklist on a clipboard doesn't mean a thing if the hospital system doesn't back it up. To make the bundle work in the chaos of a real ICU, you have to build a systemic shield. It starts at the top with system-wide standardized guidelines. Then, it cascades down into rigorous training and education. You follow that up with nonstop evaluation, audits, and visual reminders like signage. But all of this, literally all of it, builds up to the holy grail, a multidisciplinary culture of safety. And what does that actually look like in practice? It looks like a brand new junior nurse feeling completely empowered and safe to speak up and stop a senior attending physician who just forgot to wash their hands before touching a tube. That culture right there, that is what actually saves lives.
Finally, Section 5, Evidence. What actually works? Let's look at the data to separate the lifesavers from the myths.
The data from the Asia-Pacific Society for Infection Control is super eye-opening. The research absolutely confirms that VAP bundles drastically lower pneumonia rates. Another massive win? Selective oral and digestive decontamination. Basically, using targeted prophylactic antibiotics in the gut and mouth to nuke dangerous bacteria before they migrate. But on the flip side, let's bust some historical myths. Routinely changing the ventilator circuit tubing? Aggressive chest physiotherapy? The data says they have absolutely zero impact on reducing ICU VAP. In fact, every single time you disconnect that ventilator circuit to swap the tubing, you break the sterile seal and practically invite airborne bacteria straight into the patient's airway.
And the data keeps busting myths. Full-body chlorhexidine bathing? No, that is fantastic for preventing central line infections on the skin, but for VAP, zero impact. Why? Because VAP pathogens come from inside the mouth and the GI tract. Oh, and tapered endotracheal tube cuffs? They sound great in theory, like they'd create this superior mechanical seal to block fluids, but the clinical data shows they make no difference. This right here perfectly illustrates why hospitals have to fiercely rely on data-backed bundle interventions, not just assumptions. We have to focus our limited time and resources on the exact actions that actually move the needle for survival.
Which brings us to the ultimate reality of critical care. The science, it's settled. The protocols are written. The evidence overwhelmingly proves that this bundle, the strict hygiene, is the literal line between a patient going home or succumbing to a totally preventable complication. But human behavior is the ultimate wildcard. None of this amazing research matters if it's just a poster fading on a break room wall. Success depends entirely on the daily, unyielding commitment of every single person walking into that ICU. So I'll leave you with this question to chew on. Is your hospital's culture truly strong enough to make the VAP bundle an absolute guarantee rather than just a nice guideline?